side. No.
No.
Good. And so when we did the anterior thoracic, the patient pretty much laid A to P because we're working on the spine, right? And the spine is an A to P structure. So when we do the ribs, the rib angle needs to be A to P. So when we set this up to make the correction, the person needs to either be like this for a left-sided rib or like that for a right-sided rib. You all get that? Okay. So the other thing with rib manipulation, you're going to also put their hands up. So whatever side the rib is on, if it's a left-sided rib, the left hand or left upper extremity is on top. If it is a right rib, then the right upper extremity is on top. So as we discussed in class, ribs can, restrict either an inhalation or exhalation. More commonly, I find that they restrict kind of an exhalation. That they inhale and they get stuck out, and then when you exhale, they stay out, right? So when you palpate a patient and they are prone, and then you kind of, either get your TP and that kind of stuff first. If you want to do, I do sometimes the ribs, I kind of use each hand out a little bit more lateralized, so I'm on that rib angle. And so if it is restricted, it's going to be a little bit more posterior, correct? So you'll be able to feel, aha, that's the rib that's fixated. Usually when a person has a rib problem, they're going to have pain with inspiration and expiration, with breathing. It kind of hurts when I breathe. So then that's more like a rib as opposed to a thoracic vertebrae problem. So that can give you one of your indicators. Also from the history, I got hit here, somewhere like that, in terms of what's kind of going on. You want to obviously rule out it's not a broken rib and so on and so forth, and these other things that we learned last week give you information about that. We learned about how to palpate each individual rib, and the one above it and the one below it usually will not be sensitive. It's just the one that's involved, and you can use a tuning fork if you want to rule out a hairline fracture like that. Because if you do have a fracture, then this manipulation would be contraindicated until that fracture is stable. Because what you're going to do is just make it go more fracture kind of a thing. So once I've made that determination, then I can turn the patient over so that they're in their supine position. And actually I'm just going to use a model. Okay, so if the rib is problematic on the left side, and again you have them scoot down just a little bit here. That way, again, his shoulders, the top of his shoulders are not anywhere near the rib, the nose holes, all right? So if it's a left-sided problem, I'm going to, again, bring them up so that I get the scapula out of the way, fold over, and then the left upper extremity is on top, okay? So with the ribs, they're all sequential. They're all segmental, all right? And then when you look at how the ribs are, when they come out of the spine, they come out inferior and they go lateral, right? They go down and out. You all see that? So your slack for ribs in this position is down and out. And then you want the rib angle to be in one of two places, either on your thenar eminence, or it could possibly just kind of fall in that area in here. I prefer the thenar eminence, right? So you can see how my forearm is on his humerus. That way I have good control to roll him over. I'm able to palpate and find which is the rib angle, which is posterior. Go above it. Slack is down and out. Down and out. Then I'm going to roll him over and then over more, so that again his rib angle is on A to P. I have his hands, his elbows like this. The most important contact is the inferior one. So I usually, sometimes it varies on how big they are, how big, relative to my hands. But if I'm holding him like this with my thumb and first finger, you can see how when I push down that I'm creating tissue slack out of this other side of the rib cage. Which as if I had my focus here and I went to make my thrust, and I did like that, I got kind of like no leverage. So that's why it's important to contact the inferior. And if you can't grab like that, you can just focus on this one and ask the patient just give themselves a nice good hug and hold themselves, and then just make sure that when you make this correction, poke the olecranon on. But doing it like this, these three fingers are able to allow me to kind of push it down a little bit. So again, the lever is really the lateral epicondyle, the lateral aspects of the elbow, not the olecranon. Okay, so again, roll the patient over, find the level, down and out, roll them back over a little bit more. My sternum goes in the back of my hand, and then, nice, sweet. So then a correction, when I make my thrust, it is not directly A to P. It has a slight cephalad movement to it. So I'm pushing him kind of up like that with the correction, not just straight down. And so if you think of it, you just want to follow his forearm, the humerus, in that direction. So because I have to roll him over like this, if, again, with height and or an arm length, that becomes a challenge, then you can come from the same side. So if I'm going to do that, then I'm going to change arm position, right? Because the arm that's on top is the same side as the rib. So I could be on the other side and correct it, but just as a demonstration for same-sidedness. So I would grab him like this. So my forearm is still on his humerus. Roll him away from me. Find the associated or the affected rib. Slack is down and out. Roll him back over. I'm still contacting primarily the undersurface humerus. My other fingers are contacting the one on top, place on top, and then make my correction like that. So that's how you would do ribs. So understanding as well that when you do almost any thoracic spine technique, you can affect the ribs, because the rib head fits in there. They kind of go together. But sometimes you need a specific rib technique to deal with a specific rib issue. If it doesn't necessarily self-correct by using some of these other techniques that we learned, okay? Any questions on ribs? All right, let's practice those up. And then with the last several minutes, I'm going to demonstrate the other ones so you can at least see them.